Today's topic of discussion is critical appraisal of prognostic study. So what are basically the prognostic studies are? If we want to define prognostic study in proper terminology, so these are the studies in which group of people with a particular condition or set of characteristics is followed over a period of time. So जो हमारी prognostic studies हैं that will lead from cause or risk factor toward outcome. We will take some participant or individuals with certain risk factors or predictive variables which we want to evaluate over the period of time. So we will observe that participant for some time, or we will give them follow-up, and we will observe these predictive variables and risk factor, and then we will assess their influence on the outcome of disease. So that patient will have particular condition or set of characteristics that will be followed over period of time. These are known as prognostic studies, and the study design which commonly involve in study that lead us from cause to effect, from risk factor to the outcome of that variable and risk factor, that is mostly study design related to prognostic study or cohort design. So basically prognostic studies are prospective studies that lead us from present to future to assess the influence of certain factors on the outcome of disease. Commonly asked prognostic question क्या हमारे माइंड में आते हैं जब हम prognostic study से बात करते हैं? तो मोस्टली जब पेशेंट हमारे पास आते हैं किसी भी सर्टेन सिचुएशन के साथ, डिजीज़ है, पेन है, कोई मस्कुलोस्केलेटल प्रॉब्लम है, तो उनका सबसे पहले जो क्वेश्चन है अल्टीमेटली वो यही पूछते हैं कि व्हाट विल बी द प्रोग्नोसिस, कितना टाइम, कितना ड्यूरेशन, क्या चीज़ होगी कि हम इस कंडीशन से बाहर आएंगे, या जो मुझे बैकएक है या कोई मस्कुलोस्केलेटल प्रॉब्लम है या हेडेक है या थोरेसिक पेन, लंबर सर्वाइकल, किसी भी रीजन की पेन है, तो उससे अल्टीमेटली मेरी फंक्शनल एक्टिविटीज़ हैं, मेरी एक्टिविटीज़ ऑफ डेली लिविंग, इंस्ट्रूमेंटल एक्टिविटीज़ ऑफ डेली लिविंग या ऑक्यूपेशन स्टेटस, वो किस तरह से अफेक्ट होगा. इफ़ एथलीट कोई आपके पास आ रहे हैं, if certain athletes are visiting your physical therapy clinic, तो अल्टीमेटली उनका क्वेश्चन भी यही होगा कि वो कितने टाइम तक ठीक होंगे ताकि वो दोबारा से अपने गेम में इन्वॉल्व हो सकें और जो है वो अपनी जो रिकवरी है या जो अपना गेम है वो उसको दोबारा से कंटिन्यू कर सकें. तो ये मोस्टली प्रोग्नोस्टिक क्वेश्चन होते हैं. या अगर कोई सर्जरी से रिलेटेड पेशेंट है तो वो ये क्वेश्चन आस्क कर सकता है कि हाउ मच टाइम ही और शी हैव टू स्टे एट द हॉस्पिटल, और इफ़ पेशेंट और पार्टिसिपेंट इज सफरिंग फ्रॉम द सर्टेन कंडीशन, तो उनकी ये क्यूरीज होंगी कि वो हॉस्पिटल में स्टे करेंगे या वो घर चले जाएंगे. तो इस तरह की जो बेसिकली क्वेश्चंस होते हैं वो प्रोग्नोसिस से रिलेटेड होते हैं कि व्हाट इज़ द फ्यूचर, व्हाट इज़ द नेक्स्ट, क्या उनकी डिज़ीज़ जो है वो किस तरह से उनकी लाइफ को, उनकी जो सोशल सर्कल्स हैं उनको किस तरह से अफेक्ट कर सकती है. सो रिसर्च डिज़ाइन that are specific to prognostic studies. First one is cohort studies that provide data concerning the time of development of outcome. Still अभी एक outcome develop नहीं हुआ, हम उससे कंसर्न है और उसको हम टाइमली इवेलुएट करेंगे within the group and assist in defining possible causal factors in developing that condition. That if we want to know that smoking cause lung cancer, so first that individuals without any lung cancer we will take into that study, and after certain time, after 10 years, 15 years, we will follow the participant, we will observe them, and that further we will define that if participant having lung cancer or not. Then उसमें just एक smoking cause lung cancer, स्मोकिंग ही हमारे पास कॉजल फैक्टर नहीं हो सकता. इसमें मोस्टली जेनेटिक फैक्टर्स आ जाते हैं, सोशो इकोनॉमिक स्टेटस आ जाता है, एज़ वेल एज़ जो है वो पर्सनल इम्यूनिटी से रिलेटेड चीज़ें आ सकती हैं, और जो हमारे पार्टिसिपेंट हैं उनका ऑक्यूपेशनल स्टेटस बहुत मेजर रोल प्ले करता है फॉर द डेवलपमेंट ऑफ डिजीज़। सो डिफरेंट तरह के कॉजल फैक्टर हो सकते हैं जिनको ओवर द टाइम असेस करके आउटकम पे उनका इंटरेस्ट और इन्फ्लुएंस दैट विल फर्दर डिफाइन अस अबाउट द प्रेडिक्टिव variables, outcome and their influence on the occurring of outcome. The factors or risk for a particular outcome are identified and the effect is observed. Mostly cohort studies, as I have already said, that will lead us from cause to effect. What is the causal factor, what are the risk factor, and what they have done to our observed or our desired variable and outcome of interest. Example is the post-stroke are evaluated once to investigate factor that contribute to a stroke. Observed once mean इसमें हमारे पास cross sectional for the prevalence studies or where we have to define the burden of disease. Cross sectional study design भी use हो सकता है. Retrospective if we want from present to past, or historic design were also used according to this example. Next one is the case control studies. So case control studies are conducted after an outcome of interest has occurred. That is the main difference between cohort study and case control study. Cohort study outcome of interest is not developed yet. अभी हमने वो स्टडी में जो हम अपना आउटकम ऑफ इंटरेस्ट देखना चाह रहे हैं वो डेवलप नहीं हुआ. बट केस कंट्रोल स्टडी is conducted after the outcome of interest has been occurred. That we have the participant which have lung cancer, they have exposure to smoking, and some participant they also have exposure to smoking but they didn't develop the outcome of interest which is our lung cancer. So case control studies are conducted from present to past, from effect to cause. So that will be known as a retrospective study design. Case and controls are two different things. Case are the individuals that have our desired outcome or outcome or study in a group that have the outcome. And as compared to case, control are those individuals which didn't have outcome of interest. If lung cancer is the outcome of interest, then case will be that group that have participants which have lung cancer, while control will be those individuals which didn't have outcome of interest or lung cancer. Example इसमें दूसरे जो हम ऐड कर सकते हैं, that is a group of individual with repeated fall and a similar group of elders who didn't have experienced fall are studied to determine what contribute to fall. अब इसमें हमारे पास जो आउटकम वेरिएबल या जो प्रेडिक्टिव वेरिएबल है जिसको हम मेजर करना चाह रहे हैं, दैट इज़ फॉल. एंड फॉल अकर हो चुका है. अगर इस एग्जांपल में हम देखें कि सर्टेन पॉपुलेशन ऑफ द एल्डर्स, अब एल्डर्स तो आउटकम ऑफ इंटरेस्ट हमारे पास नहीं है, हमारे पास आउटकम ऑफ इंटरेस्ट है फॉल. कि एल्डर्स हैं, कुछ लोग हैं जो फॉल जिनमें रिपोर्ट हुआ है एंड एट द सेम टाइम सेम पॉपुलेशन, सेम सिचुएशंस एंड सेम इन्वायरमेंटल फैक्टर्स. कुछ लोग हैं जो उसी कैटेगरी उसी एज के हैं बट दे डिडंट हैव फॉल एंड वी वांट टू नो अबाउट द कॉज विच लेड टू द रीज़न ऑफ फॉल. सो फॉल हैव बीन अकर्ड, आउटकम ऑफ इंटरेस्ट हैज़ बीन अकर्ड एंड वी विल मूव टूवर्ड बैक फ्रॉम effect to cause to find out the reasons which cause the fall in that population. Next one is cross-sectional study design. That are those study design that data are collected at one point in time. The important factor is that subjects are measured once. Basically cross-sectional studies are related to find out the burden of disease, or as already said that data is collected one point of time, or to find out the burden of disease and prevalence of disease and certain population. So subjects are measured once and at the same point in disease, injury and rehabilitation process. अगर इसकी एग्जांपल्स की अगर हम तीनों स्टडी के एग्जांपल्स की बात करें तो एक एग्जांपल से मैं आपको आगे डिफ़ाइन कर देती हूँ. दिस एग्जांपल विल क्लियरली demonstrate or clearly elaborate the three design. Number one is the cohort design, that we have the individual at the age of 20. As already said, that cohort design are prospective study design that will lead us from cause to effect, from present to future. So at present the individual is at the age of 20 and reading or data collection is time 1, and after age 70 again data is collected for the gap of 10 year, age 20, 30, 40, 50, 60 and 70. 6 times एक मेजरमेंट ली गई है इंडिविजुअल से और आप देखें कि उनको ऑलमोस्ट 50 ईयर तक फॉलो अप लिया गया है उस चीज़ का. टू फाइंड आउट द कॉज and to check the selected predictive variables and outcome of interest. So these are cohort design. Next is the cross-sectional design. At the age of 70, only one time at one point of time certain situation पे or at same point of injury, rehabilitation process and stage of disease एक चीज़ मेजर की गई है, that is the rate of heart attack in group of 70-year-old man with risk factor for heart disease. के 70-year-old मैन हैं और उनके साथ जो रिस्क फैक्टर हैं और हार्ट डिजीज़ है उसको एक वन पॉइंट ऑफ टाइम मेजर किया गया है. दैट इज़ क्रॉस सेक्शनल स्टडी डिज़ाइन. नेक्स्ट we have the case control design. As already said, that case control study design are those design which are the study that already have developed the outcome of interest, and in current scenario and example outcome of interest is heart attack. So study will study those participants who are at the age of 70 who have developed the heart attack and 70-year-old men who didn't have heart attack. The old men which have heart attack, that are our case, and the people who didn't get heart attack, that will be our control. The process of study appraisal have 4 essential part, as this is the third step of EBP. The part 1 determine the study applicability, part 2 determine study quality, part 3 determine or interpret the study results, and part D or fourth part, that is summarizing the clinical bottom line. So first is the process of study is determining the study applicability. The question will be, is the study relevant to my clinical question? करंट सिनेरियो में अगर मैं कुछ देखना चाह रही हूँ, फाइंड आउट करना चाह रही हूँ लो बैक पेन से रिलेटेड जो हमारे पास कॉज हैं कि क्या कॉज हो सकती हैं, तो मैं प्रीवियसली लिटरेचर पर जाके सर्च करूँगी आर्टिकल्स जो लो बैक पेन पर होंगे या दैट विल बी क्लोजेस्ट टू माय क्लिनिकल क्वेश्चन और माय क्यूरी विच आई हैव टू फाइंड आउट or I want to see in my patient. So already defined in previous video, we will only read the abstract or topic of the discussion or topic of that research article that will be closely matched to the subject of my study. But we cannot find those article and abstracts and research studies that 100% match to our recent scenario which we are dealing. So first will be the is study relevant to my clinical question, कि आप जो टारगेटेड पार्टिसिपेंट हैं जिनको आप स्टडी कर रहे हैं और उन्हीं से ही रिलेटेड आप कोई एविडेंस बेस्ड आर्टिकल्स फाइंड आउट करना चाह रहे हैं तो जस्ट उन्हीं पे ही हम फोकस करेंगे. नेक्स्ट क्वेश्चन विल बी, इज देयर डिफाइंड रिप्रेजेंटेटिव सैम्पल ऑफ द पेशेंट assembled at a common point that is relevant to study question. इस सिनेरियो को इस तरह से हम करेंगे कि हाउ द participants are included in the study. We will define the process of participant accumulation and collection or indulgence in the study. The process may be either through randomization, either through lottery method, either informed consent, or who are willing to participate in the study any scenario can be a possibility of any scenario. So that will be the representative sample of the patient, then assembled at common point of time कि आपने जो भी participant लेने हैं that should be at the similar stage of the event of interest or the outcome of interest which we are going to find out. Means if we are going to study the backache, low backache, so we will already define in inclusion criteria that study participant will be either at acute stage of the low back pain or in chronic stage, or also define the nature of low back pain, either it's specific low back pain or non-specific low back pain. So participants should be at the similar stage of the event of interest so that in future our study results should not be disturbed by that difference in the staging of the disease. It is important that all subjects are measured at study outset on the primary outcome that will use to detect change in status. तो हमारे पास एक प्राइमरी आउटकम होना चाहिए. प्राइमरी आउटकम इन टर्म ऑफ पेन भी हो सकता है, इन द केस विद लो बैक पेन रेंज ऑफ मोशंस भी हो सकती हैं, और एनी काइंड ऑफ डिसेबिलिटी भी जो लो बैक पेन की वजह से उस पेशेंट ने सफ़र की है, उस तरह की चीज़ें इसमें हो सकती हैं. So these are the two scenarios, all subject with back pain. Adults with back pain at 20 to 40 year, 41 to 60 and 61 to 80 year. And then again in this scenario we have taken adults, male female both genders are included in first circle, while if we are going to take a look over second circle, that there will be the adults, female adults with back pain age 20 to 40, 41 to 60 and 41 to 60 and 61 to 80, females and then males. They are clearly defined that what we have which participants are included in our study with the age, with proper clearly defined inclusions criteria. Were endpoints and outcome measure clearly defined? Study should be specific about the detail how participant change in the status will be measured. Before intervention and after intervention, or before any treatment and after treatment, how patients are measured or how our specific outcome of interest are measured. For that purpose, we use standardized outcome measure. Standardized outcome measures different nature के हो सकते हैं. For example, for the pain, we measure numeric pain rating scale, that is our standardized outcome. For disability, we use mostly Oswestry Disability Index. For range of motion, goniometer and clinometers can be used. So standardized, these are all the standardized outcome which can be used to measure our outcome of interest at the end point of study. Are the factors associated with outcome well justified in terms of potential for their contribution to prediction of outcome? कि आप जो भी अपना प्रेडिक्टिव आपका वेरिएबल है और द प्रेडिक्टिव रिस्क फैक्टर, उसका प्रॉपरली आपके पास एक लॉजिकल रीज़न होना चाहिए, एंड दैट शुड बी ऑल्सो कंबाइंड विद द प्रीवियस लिटरेचर. दैट इज़ द बेसिक्स ऑफ एविडेंस बेस्ड प्रैक्टिस, कि आपके पास अपनी क्लिनिकल लॉजिकल रीजनिंग, प्रोफेशनल एक्सपीरियंस एज वेल एज दैट शुड बी कंबाइंड टू द लिटरेचर, that you can justify that outcome of interest which we are going to measure, that is specifically and basically occurring due to some predictive variables and potential risk factor which are going to cause that outcome of interest. Next one is, were evaluators blinded to reduce bias? As already discussed in the previous studies, all outcome of measures are subject to bias. When possible, it is ideal for the researcher that evaluators should be blinded to the primary hypothesis and previous data collected by a given participant. जितना level of blindness हम increase करते जाएंगे, either the study is single blind, double blind और triple blind, उतना ही study के results, outcome of interest और study के जो results हैं वो precise होते जाएंगे. अगर आप 3 लेवल की जो हैं वो ब्लाइंडनेस नहीं ऐड कर सकते स्टडी में, तो आइडियली मैक्सिमम मिनिमम जो आप कर सकते हैं दैट इवेल्यूएटर्स ऑफ द आउटकम, कि जो आपके थेरेपिस्ट हैं या जो आपके असेसर हैं या जो इवेल्यूएटर्स जो प्री एंड पोस्ट आउटकम मेजरमेंट्स मेजर कर रहे हैं, दैट शुड नॉट known to the treatments given to the group, that should not ideally known about the hypothesis, study objective or problem or question which we are dealing, that should not know all these factors that will contribute to precision and further reduce the biasness of our study. Was the study time frame long enough to capture the outcome of interest? Study should report anticipated follow-up time in the method and actual follow-up time in result. तो follow-up time हमारे पास इतना sufficient होना चाहिए that should ensure that outcome of interest has sufficient time to develop in study participant. ये नहीं कि हम जो outcome of like smoking cause lung cancer, अब एक दिन स्मोकिंग एक इंडिविजुअल अगर एक पार्टिसिपेंट आपका जो है वो स्मोकिंग करता है, स्मोकिंग की हैबिट है उसकी, नेक्स्ट डे ज़रूरी नहीं कि उसमें लंग कैंसर डेवलप होगा. दैट विल टेक इनफ टाइम टू डेवलप लंग कैंसर. सो द आउटकम ऑफ इंटरेस्ट विच वी आर गोइंग टू मेजर विद द रिस्क फैक्टर्स एंड प्रेडिक्टिव वेरिएबल्स, दैट शुड हैव इनफ टाइम फ्रेम फॉर द फॉलो अप टू चेक द आउटकम एंड मेजर द आउटकम ऑफ इंटरेस्ट. Was the monitoring process appropriate? That study should report how information was collected, or either in research term we use the data collection procedure over the length of study. We have a valid and reliable data collection procedures and does not cause participant to substantially differ from the general population. We have valid and reliable measurement procedures, measurement methods and observation method that will assess our monitoring process and will declare that monitoring process was appropriate. Were all participants followed to the end of study? जितना ज़्यादा greater the percentage of the participant completed the study, that will be the better. Ideally हम कहते हैं कि greater than 80% जो आपके study participant हों वो retain रहें, आपका follow up लें और आप उनसे follow up data भी collect कर सकें. तो आइडियली 80% मोर देन, अगर आपका स्टडी सैम्पल है उसका 80% मोर देन 80% इंडिविजुअल शुड फॉलो द स्टडी एंड यू हैव कलेक्टेड द डाटा फ्रॉम द 80%, बिकॉज सब्जेक्ट एट्रिएशन जो है वो मेजर रिस्क फैक्टर्स हैं टू कॉम्प्रोमाइज़ द क्वालिटी, एप्लीकेबिलिटी एंड इंटरप्रिटेशन ऑफ द रिजल्ट्स. जितने ज़्यादा सब्जेक्ट लॉस होंगे, पार्टिसिपेंट फॉलो अप लॉस करेंगे, उतना ही क्वालिटी ऑफ स्टडी जो है वो कॉम्प्रोमाइज़ होती जाएगी. Next is what statistics were used to determine the prognostic statement. Were the statistics appropriate? Statistical analysis for the interpretation of results are the main and major important component of any research problem and research articles. So basically common statistics that used in prognostic rehabilitations are correlations, linear and multiple regressions and logistic regressions. Next, for the statistics used in epidemiology, in prognostic study, that we use relative risk that are expressed as odd ratio and risk ratio. First statistical test that used is correlation. Correlation is basically measure of the extent to which two variables are associated. कि दो variables एक दूसरे के साथ कितने associated हैं. Either they have direct relation or inverse relation. If one variable is going to increase, second variables will automatically increase with that. So these will measure the variable change together, and the pattern of change or association of the two variables known as correlation coefficient, that is represented by small r. Value of r may be vary between -1 and +1. -1 mean if values lie between -1, that mean that have negative correlation or inverse relation, or if variable have +1 value, that will define that two variables have positive correlation or direct relation. These are the R values, and that will be determine our strength of the study. The value range from 0.0 to 1, 0.0 to 0.25 that show that two variables have little or no relationship, 0.26 to 0.49 that mean two variables have low association regarding the change, 0.5 to 0.69 that have moderate correlation, 0.70 to 0.89 have high relationship between two variables or have high association, 0.90 to 1 show very high correlation between the two variables. That means two variables are directly proportional. Second statistical test that is used is regression, that is used to make prediction from one or more variable to an outcome of interest. Regression analysis basically is the process where we are going to estimate the relationship among the two variables, dependent variable and independent variable. Independent variables are the predictors. If I can explain it through the example, if our research topic is that plant grow faster in warmer temperature, in that scenario temperature is the independent variable and what we are going to measure that is the plant growth, that are the dependent variable. कि plant growth जो है वो temperature dependent है और temperature itself is independent variable. Next example कि to what extent does traffic affect a person mood, कि कितना जो हमारा road traffics हैं वो एक person के mood पे कितना affect कर सकते हैं. So traffic is our independent variable and mood that is depending upon the traffic ratio, that is our dependent variable. Next अगर third example मैं इसकी define करना चाहूँ that people walk slower after drinking coffee. Drinking coffee is the independent variable and what is depending is walking speed, के जो हमारी वॉकिंग स्पीड है वो कॉफ़ी पीने के बाद कितनी अफेक्ट हो सकती है. तो ये इस तरह के जो डिपेंडेंट एंड इंडिपेंडेंट वेरिएबल्स उनके दरमियान में हमारा जो रिलेशनशिप है एंड आउटकम ऑफ इंटरेस्ट हम मेजर करना चाहते हैं, दैट इज़ फाइंड थ्रू द रिग्रेशन. दैट इज़ डिवाइडेड इनटू फर्दर सिंपल लीनियर रिग्रेशन. इफ़ वी आर समराइजिंग द स्टडी रिजल्ट्स and the study relationship between two continuous quantitative variables, that we will use simple linear regression, that is denoted by y is equal to a plus bx. One variable denoted by x is regarded as predictor, explanatory or independent variable, and other variable that is denoted by y is regarded as response, outcome or dependent variable. Multiple regression is the extension of simple linear regression. In multiple regression we are going to find the prediction or variable that have two or more than two variables as shown in the equation. Y is equal to a plus b1 x1 b2 x2. One is the dependent and second one is the independent, but variables are more than two or more than two variables that should be calculated or analyzed through the multiple regression. Logistic regression are those model where dependent variable is categorical, mean dependent variable having the two output, only two values 0 or 1, pass, fail, win, loss, alive, dead, healthy, sick. अभी हमारे पास healthy sick variable है, alive and dead हमने इनसे जो डाटा कलेक्ट करना है ये हमारे two variables हैं, but that are those variables which have only two outcome or two values that are also known as our categorical variable or binary dependent variable. Relative risk ratio, that are the statistical analysis mostly used in case control study. These ratios are used to express the odds of occurrence of a particular outcome between the case group and control group. Okay, if participant is facing the same situation, the participant have exposure, both case and control have exposure to certain situation, but case are the individual who have developed the disease and control are those individuals which didn't get that outcome of interest or disease. So what are the reasons, what are the odds of occurrence of particular outcome between the case and control, that should be measured through the relative risk ratio and risk ratio or ratio. So risk ratio are the probability of event occurring, for example developing a disease, being injured in exposed group and developing of disease in non-exposed group, denoted by R is equal to A over A plus B divided by C over C plus D. Odd ratio is the measure of association between an exposure and an outcome. Odd ratio represent the odds that an outcome will occur given a particular exposure compared to the odd of outcome occurring in absence of that exposure. And odd ratio is equal to AD over BC. So if I can explain the risk ratio and odd ratio through that example. We have example or scenario that individual have lower extremity injury, that is our outcome of interest, and risk factor is muscle imbalance. कि muscle imbalance का कितना impact है for the lower cause of the lower extremity injury. So कुछ ऐसे individual भी हो सकते हैं कि जिनको muscle imbalance है and they got the lower extremity injury, that will be our positive case. फिर कुछ ऐसे individual होंगे that have positive risk factor, mean they have muscle imbalance but they didn't got the lower extremity injury, that will be our scenario B, negative no. Third one will be those individual which have positive risk factor as well as also they have the lower extremity injury. एंड कुछ ऐसे इंडिविजुअल होंगे कि जिनमें मसल इम्बैलेंस भी नहीं है और उनको नेगेटिव भी नहीं हुआ. दो मतलब इनकी एक्सट्रीम्स हो सकती हैं कि अगर इस एग्जांपल से शो करें कि कुछ इंडिविजुअल्स हैं कि जिनमें मसल इम्बैलेंस है बट दे गॉट लोअर एक्सट्रीमिटी इंजरी, बट देयर विल बी सर्टेन इंडिविजुअल विच हैव मसल इम्बैलेंस but they didn't got the lower extremity injury. So these odd can be calculated by 2x2 contingency table easily from the previous example as A over A plus B, C over C plus D, that will calculate our risk ratio, and odd ratio AD over BC. That example can easily solve through that process. Were clinically useful statistics include in analysis? कि हमने जो स्टैटिस्टिकल स्टेटमेंट्स हैं वो ऑर्थर ने या जो प्रीवियस स्टडीज़ हैं, रिसर्च आर्टिकल्स हैं, उनमें एप्लीकेशन जो है वो पेशेंट्स पे अप्लाई की हैं या नहीं. Will this prognostic research make a difference for my recommendation to my patient? If we are going to take prognostic studies and prognostic strategies, how that will affect my patient management and my outcome of interest, or how that will affect my clinical techniques, clinical outcome. Either that study will help to the community and population, and clinically basically study is useful for clinical purpose or not. So that's all related to critical appraisal of prognostic study. Thank you.